Good evening, everyone. Welcome to the Center for Advocacy and Social Justice at the Jacksonville Urban League. Tonight we have a presentation that's sponsored in part by the Black Health Professionals Collaborative that is in its formative stage, connecting with the Northeast Florida Medical Society, the Black Nurses Association of the First Coast, and the NAACP and the Jacksonville Urban League. This is a very important event tonight because we're going to hear a post-legislative session roundup, if you will, on health legislation and important issues related to access to healthcare, but also as part of our oral health access initiative, we are also very fortunate to have two leading lights in the field of lack of equity in access to dental health. And they will be presenting on those problems to us this evening. So we're very grateful to them. And I will get started with, first of all, a thank you to all of the interns that have helped make this possible and make other presentations like this possible. And I would also like to thank my colleagues at the Urban League for making this happen. So with that, I will introduce our panel and have them introduce themselves. We have, speaking first will be Scott Darius of Florida Voices for Health. Caswell Evans will be speaking on oral health equity, and Dr. Frank Catalanotto speaking on the results of poor oral health solutions to that. So with that, I'll ask each of you to introduce yourselves. First of all, Mr. Darius.
Hey everyone, thank you for having me. Pleasure to be here with you all. Scott Darius, Executive Director at Florida Voices for Health. I'll share a little bit more in a minute, but we're just a statewide health advocacy organization, and our mission really is to help increase access to care for low-income and middle-income Floridians.
Thank you. Dr. Evans.
Yes, good evening. I'm Dr. Caswell Evans. I'm an emeritus professor at the College of Dentistry in the School of Public Health at the University of Illinois at Chicago. I'm a past president of the American Public Health Association and the American Association of Public Health Dentistry, and I'm very pleased to be with you this evening.
Thank you very much. And Dr. Catalanotto?
Great. So Frank Catalanotto, I'm a pediatric dentist by education and training. I've been a long-term faculty member and former dean of the University of Florida College of Dentistry. And I am one of the leadership team for Floridians for Dental Access, which is trying to get some legislation passed in Florida to bring dental therapy to the state. And I also have to say, it's on my slides later on, but I am expressing my own personal opinions and any comments I make tonight, and they do not reflect on the opinions of any other organization I am associated with, except Floridians for Dental Access.
Well, I want to thank you, Doctor, particularly for the partnership that we formed on the issue of access to better oral health for underserved communities. In fact, it was your coming to us with this that really helped us expand our efforts to deal with health gaps generally. And so we now have several of our interns working on this issue, and we've been working with the Population Health Consortium, another great supporter of these oral town halls, or excuse me, town halls that the Center for Advocacy and Social Justice puts on. So thank you very much. with that, I will ask Mr. Darius to start off our panel.
Sure thing. I don't know if you all received my slides from earlier, but if not,
I think Jocelyn is
Yes, I
taking
have
those.
them. I can share my screen now.
awesome. Thank you, Jocelyn. We'll just start on the second slide. So for those of you who might be new to us, Florida Voices for Health, like I mentioned, we're just a statewide health advocacy organization. We'll just start on the second slide. And our mission is to help increase access to care for low-income and moderate-income Floridians. We're lucky enough to get to do that work in coalition with a lot of great partners around the state. So if you as an individual or an organization would like to join in and kind of be plugged into the work that we're doing, we'd love to have you. We work on a number of issues, primarily Medicaid expansion, but also looking at improving access to oral health and a number of consumer protection bills. Next slide, please. So really, my goal today is to kind of help paint a picture of the healthcare landscape in Florida. Coming off of a pandemic, we really expect to see an overworked safety net system and an overall healthcare system that's been exposed in a lot of ways. Unfortunately, and maybe fortunately, the pandemic has mostly uncovered it's uncovered just how fragile of a system we have. I think it's really opened our eyes to just how many people, how many Floridians were living on the edge, particularly those in vulnerable communities. Even before the pandemic, Florida had the 4th highest number of people who were uninsured among all 50 states. And that's despite leading the nation in enrollment, ACA enrollment, and that's for a couple of years running. And I really think that that's a great indicator for just how many people in our state need better access to healthcare. In the years since, and as we'll see in a minute, post-pandemic, things have really only gotten worse. When it comes to oral health, and I know Dr. Frank will go more into these, but just kind of setting the stage, we know more than 5 million Floridians are living in areas where they don't have access at all or just have very limited access to an oral health provider. And when it comes to children, we've seen, and after making years of dramatic improvement to our children insurance rate, we've seen over the last few years that the number of uninsured kids has gone up. In fact, between 2016 and 2019, the Georgetown Center for Children and Families has estimated about 55,000 kids who have lost coverage. Next slide, please. So looking at this another way, at outcomes. We know that outcomes and prevalence of certain conditions, it's really an important metric to kind of examining where we are on the landscape. Overall, Florida's not the healthiest state, and so it would probably work to our advantage to build a healthcare system that takes that into account and really helps us to move to keeping a more productive society. About half of all Floridians have a chronic condition, and it follows that over half of all Floridians have at least one condition that could be considered pre-existing. Now, this map over on the side comes from the county health rankings, and it looks specifically at health outcomes, which really are it's a combination of the measures of how long people live and how healthy people feel. They broke it down into quartiles, and it really is a comparison of Florida counties versus each other. And we can see, looking at the map, the places in the state where we have the most room to make improvement. One thing I like to point out is that even in the places where there are lighter shades of green, we know that within those counties that there are specific communities where the outcomes are poor. So looking at Miami-Dade, for example, we know that there are places like Liberty City where the outcomes don't keep up with where the county is generally. Next slide, please. Another metric worth looking at quickly, I think, is affordability. And there really are a lot of ways to slice that affordability conversation, or to have it, and its impact on Floridians. But maybe the main point worth taking away here is that the biggest barrier to care in the state is just how expensive it is to access any form of healthcare. And that's something that we'll dive into a little more. But this stat comes from a project we did with the Altarum Institute in 2019, where we partnered to run a survey throughout the county or throughout the state. And we found that 55% of Floridians faced at least one healthcare affordability burden, which means that they either delayed care or they paid for care at the expense of something else. They either cut pills or found some other workaround to access the care that they needed. It's really a fascinating report and one that we broke down based on the different regions of the state. So a full report is available at this link for anyone who's interested. Next slide, please. I thought it might also be helpful just to share some high-level points on where we are with healthcare in rural parts of the state. We see that COVID has taken its toll in some of our rural counties. There's a report here from Jacksonville University that we cite, and that report also found that the high death rates were directly tied to the poverty levels and inability to access healthcare that's more prevalent in rural counties. I think another revealing metric when it comes to the availability of care in rural, in the rural parts of the state is looking at the availability of physicians, of primary care physicians. The Florida average, right, is about there's one primary care physician for every 1,200 Floridians, but in some rural counties, we see a much greater ratio. And then additionally, the uninsured rate for low-income Floridians in rural areas is about, on average, 13% higher than in metro areas. So I think in some urban communities, you'll see the uninsured rate closer to 24%. And on average in rural Florida counties, that percentage is closer to 37. And in some places, it's way beyond that. And that doesn't even begin to address the hospitals that we've seen shut down over the last few years. I think, Jocelyn, if you click it one or two more times, it'll pull up a different graphic. There we go. We know that there have been 7 hospital closures in Florida since 2005. 3 of them closed last year. That's Shands Stark Regional. Shands Stark Regional, Shands Lakeshore, and Shands Live Oak. So places that we know people rely on as where they receive primary care have shut down, and we've seen that trend only continue in the last year or so. Next slide, please. And so while we've talked about coverage and access, I think it's worth doing a little deeper dive into Florida's uninsured rate. There's so many Floridians who are uninsured who actually just have 0 options for care. And they're in what we call the coverage gap. What some of you might not know is just how hard it is to qualify for Medicaid here in Florida. First, you have to have a dependent child. And regardless of how little you make, if you don't have a dependent child, you don't qualify for care. Secondly, and exclusively for adults with dependent children, the most you can make in the state and qualify for Medicaid is 31% of the federal poverty level. That means for someone in a family of 3, the most you can make for a year and still qualify for coverage is $7,000. Now, Medicaid expansion would cover folks making up to 138% of the poverty level. And before the pandemic, that meant about 800,000 people. The latest estimates we've seen from CMS is that number has gone up to 1.1 million people who would benefit from Medicaid expansion. Now, I threw in just a little bit extra, which is that decision to reject Medicaid expansion is costing the state $200 million a year in savings. And on top of that, we're missing out $3 billion, an additional $3 billion that was offered by the American Rescue Plan that passed earlier this year. Next slide, please. Now, I think it's also critical to look at the healthcare landscape through the lens of health equity. It's no surprise that as a country and as a state, we really have a long way to go to ensure equitable outcomes and access for communities of color. Almost a third of direct medical costs faced by communities of color can be tied directly to health inequities. And we know that half of the people who would benefit from expansion in this state come from communities of color. About 29% of those who would benefit from expansion are Hispanic, and 22% are Black Americans. Next slide, please. And finally, I wanted to quickly highlight where we are with oral health, again, to kind of help set the stage for what we'll hear from Dr. Frank. But really, Florida Voices for Health, we got a small glimpse of how things have played out since the pandemic through a series of roundtable conversations that we held last year with oral health stakeholders. It primarily featured dental professionals, administrators, advocates, a couple academics, folks representing the free and charitable clinics, and the federally qualified health centers. Through those conversations, we found that among the most significant barriers to oral health, again, I'm sure is no surprise, affordability and the lack of providers, like I mentioned earlier. Now, specific to the impacts of COVID-19, we've seen increased costs for providers, and we also saw an increase in the number of uninsured that the safety net is really left to deal with. Next slide, please. So it's really in this context and this landscape that we came into the 2021 Florida legislative session. The 60-day session ended April 30th, so only 2 weeks ago. And the highlights, I listed a couple of the healthcare bills that passed, and there are a whole lot of highlights, so I won't go too deep into them, but I'm happy to answer any questions. Really, the only immediately meaningful improvement to health access was the extension of the Medicaid postpartum coverage. Before it passed in the budget, women who were eligible for pregnancy Medicaid really only received Medicaid for 60 days after pregnancy. So, they have the baby, 60 days later, they lose coverage. With this extension, they now have a full 12 months, which we know is critical to the life of the mother, but also the health of the baby. Now, every other bill we saw pass this session related to healthcare really just kind of tinkers around the edges of the healthcare system, but don't take a full-throated step forward in improving access. Next slide, please. And so while the legislature's priorities are really driven by any number of factors, and that's ultimately reflected in the final budgets we see in the final pieces of legislation they passed, for us as Florida Voices for Health, our agenda is primarily driven by the stories of the Floridians we get to talk to. This is just one example. And frankly, the sheer amount of stories we get related to the lack of access to dental care stands out. It's a common problem and it plays out a million different ways. Callie from Pinellas, which is a story we have highlighted here, we had the honor of capturing her story, and it really just highlights the wide-ranging impacts that having dental pain and having to live with it has on people's overall lives. Next slide, please. So really, that's why, considering that our agenda is driven by the people we get to talk to, it's why we were disappointed to see such little movement on the bills that would have had impact on access to oral health. Again, we'll hear more in a minute on dental therapy, so I just have a brief description listed up here. But we also had the opportunity to expand not just who qualifies for Medicaid, but also the package of services that are provided as a part of Medicaid. But the adult dental benefit wasn't considered at all this year, though it's something we hope to continue pushing in future legislative sessions. Currently, the adult dental benefit only covers emergency services, and I think that that's left to, there's not a hard definition on what is actually included in that package. But the comprehensive dental benefit would allow folks to get everything from preventative care to major procedures done, and really it saves the state quite a bit of money when you think about how much we pay in emergency room costs for preventable oral health episodes. I guess the broader point to this slide is that solving the challenges in our healthcare system, including oral health, will inevitably require multiple solutions. I'm excited to be in spaces like this because it's where the momentum for that real lasting policy change begins. Next slide, please. And so you probably aren't terribly shocked to hear that so few of the laws that pass, the legislation that's passed, it's done with little or serious consideration of how it impacts average Floridians. For us as Florida Voices for Health, we see our role as bridging the gap between the stories of Floridians and lawmakers. So we exist here to share those stories directly with lawmakers, directly with members of the media, and right back into our communities. And so we really invite all of you to join us in that work. Next slide, please. And just quickly to close this out, here's some of the ways you can do that. We have a full-time story banker who I can't say enough good things about, but she really takes the time to sit and listen, to hear people out, refers them to resources where she can, but I think more importantly, ultimately empowers people to use their own voice for change. So feel free to reach out to us via email or by using our online form. And on the next slide, please, you'll see all the different ways you can engage with our Medicaid expansion campaign if that's something that you're interested in. We'd love to have all of the thought partners and anyone who's willing to put a hand in that work. And so, yeah, that's my update. Thanks for having me, and I'm here to answer any questions. Dennis, I think you're on mute.
Thank you so much. While I have you on the dais, even though we've got a Q&A at the end, you know, every time we see these statistics, it's shocking. And I see there is a coalition working together, and we've worked with your group helping to find voices in our region. But I'm wondering, what is your sense of, let's call it the movement to fill the gap? Is there increasing concern and is it driving more people and more organizations to get involved?
So that answer exists in two different worlds, right? On the legislative side, we thought the landscape had changed enough to create some real momentum. You had a pandemic with a lot of people struggling. You had financial incentives coming from the federal government, and you have the experiment playing out in the 38 other states that have passed it. And none of that has been enough to kind of move the dial, move the needle at all with our legislature. And that was with facing significant budget deficits this year. But on the coalition side, like on the ground, you see more and more of our partners, new partners are coming to the table. And it's really helped us to, I think, spark the movement that spark the next phase of the work, which, you know, we'll keep pushing on the legislature the best that we can, but the momentum around a ballot initiative has really picked up. And that's even despite some of the anti-ballot initiative bills that we've seen from the legislature this session.
Well, thank you very much. It certainly motivates us to stay involved and continue to work with you. And we look forward to doing that over the next year as we go forward in this very necessary effort. And I believe our next speaker is Dr. Evans.
I believe the session that we've planned will start with Dr. Catalanato, and then I will chime in
very
and
good.
he will speak again. So thank you.
Thank you.
Well, actually, no, Caswell, you're going to go first. Your slides are first in the slide.
All right. Are
Okay.
you going to provide the introduction, Frank?
Yeah, so yes, I will. So I represent an organization called Floridians for Dental Access. And Dr. Evans and I are both members of a new organization called the National Coalition of Dentists for Health Equity. Our primary focus at the national level is health equity issues. Our focus at the state level is to try to get legislation passed about dental therapy. So Jocelyn, you can go to the next 2 or 3 slides, because we've already introduced ourselves. That's my bio sketch and disclaimer. Next slide, Jocelyn. And a little more information about Dr. Caswell Evans. Next slide. And Caswell, you can take over from here.
Okay, thank you.
Slides.
I'm very, very pleased to be with you. And I want to talk a bit about oral health and provide perhaps a conceptual framework that is helpful and make a distinction between dental care and oral health. I think we can go to the next slide. This one speaks for itself. So oral health is about teeth, certainly, and dentistry is probably more focused on teeth than oral health. But consider that oral health has a number of ramifications and implications for one's life and lifestyle. First, oral health is fundamental to our ability to speak. Everything that we drink, everything that we eat is dependent upon our oral health capacity. Because our oral health affects what we eat, it affects diet, it affects nutrition, which is certainly an issue as we age. Oral health is also how we see ourselves, our self-image. It's also important that it's a function of how other people see us. Another aspect of oral health that I think we've probably all experienced, you've been in a group and there's a moment of gaiety and laughter, and you see someone cover their mouths because of their discomfort laughing in public. I've seen that with children, and just think how that affects them psychologically and socially. Oral health is also important in terms of employment. Consider someone with poor oral health presence is most unlikely to be able to even serve hamburgers in a McDonald's. It's also then important for people who may be promoted. Oral health status in one position doesn't necessarily favor one's consideration for promotion. And there are oral health equities that Dr. Catalanato has addressed, and we'll be talking more about those in a moment. But I want to put that also in perspective. When you think about access to care and you think about oral health inequities, it can simply be stated that the population cohort the population cohort that is comparatively least in need of care consumes the most care. The population component that is most in need of care receives the least. Now, that latter population that is most in need of care and receives the least is not a randomly distributed population cohort entity. It's largely comprised of the elderly, people of color, people in inner city urban environments, rural populations, the poor, and those who are institutionalized, and those who have other serious underlying health conditions. So the population that is most in need of care but receives the least care and has the greatest problem of access to care are comprised of those population groups. So there is social inequity. One might call it social discrimination. And that is one of the problems that faces the oral health service system. Private practice of dentistry are individual dentists distributed typically in communities that can pay their fees, and others as already described, those types of populations and communities are left with major disadvantages in terms of access to care. So we feel that, as Dr. Catalanato has already referenced, that the oral health workforce entity needs to be expanded. Other oral health providers brought on, as is occurring in many states now, and that is basically represented by dental therapists, who can certainly fill in many of the gaps and provide services to populations and communities that have these access to care difficulties and oral health inequities. So I've already addressed this particular description of the inequities, and I think that that's a simple way of understanding the issues of access to care and oral health inequities. I think with the next slide, we can go to Dr. Catalanato. Yeah, and I've already addressed this. Yeah.
Yeah, one more slide.
One more.
So this just provides some of the data that backs up what Dr. Evans was saying. So any of the national surveys that you look at, we clearly are starting to do a little better in overall health for children, but race and ethnicity and poverty status still drags down the improved oral health in both children and adults by virtually every survey that you look at. Next slide. So why is oral health important? Why are we trying to develop policies and methods to improve oral health? So as Dr. Evans said, oral health is way more than just the teeth and the smile and how people look, but it's this function to eat, this function to speak, how they look, their employability, and there's good data to support every one of those concerns. But even more importantly are the publications over the last 10 to 15 years that show the relationship between poor oral health and overall systemic health, your body health. And therefore, if racial and ethnic minority groups and lower income groups suffer more from oral health, that's going to relate exactly back to the problems that Scott Darius spoke about in the beginning of this presentation about poor overall systemic health. Next slide. And I wanted to just use one example here of a report from 2019 from the Blue Cross Blue Shield Association about the relationship in their customers, their insurance customers that had both medical and dental insurance. And you look at that, 25% more likely to have heart disease, management of diabetes and other diseases, twice as likely to visit a hospital emergency room if you have poor dental health, but visit that emergency room for systemic overall health conditions. And that last sentence, members with poor oral health had nearly 2 fewer years of healthy life, according to this study. I mean, that should be a shocking number to any of us. Next slide. So the other issue is the effect of poor oral health on school performance. And I'd like to introduce this slide with an anecdote about a survey we did in Gadsden County, right next door to Tallahassee, a number of years ago at the request of one of our graduates, Dr. T.K. Tibby, who was running the county health department at that time. And we did a 3rd grade surveillance. So that's sort of a standard grade to do surveillance studies across states, so you compare states. And 1 in 5 children on the 2 days we did the survey were in dental pain. And my question is, how are you going to learn? What's the way out of poverty for poor children and poor adults? It's education. It's that education that's going to make the difference between a job at Walmart and maybe a better job than that in the workforce. So every one of these measures that I've had here, and I'm not going to read them all out, these are all backed by literature, published peer-reviewed literature, showing poor school performance in kids with poor oral health. Next slide. And so this is not a problem of what I will call us progressives. We're not making out this to be a problem on our own. This is a quote from a wonderful paper by the head of the American Dental Association Health Policy Institute. And basically, the dental care delivery system, as he described it, is broken. And he offered a number of suggestions about what to do about it. One of them was related to workforce. Next slide. And so when you look at the numbers, and this is estimates, again, not by folks like myself, who honestly might be biased in terms of trying to bring more healthcare to others. But this is from HRSA, the Health Services, Resources and Services Administration. And this is also, again, from the American Dental Association Health Policy Institute. It's roughly 180 to 190 million people in the United States cannot get dental care on a regular basis. And I'll have something more to say about that in a minute. Next slide. So here's Florida. The feds define health professional shortage areas. They also define specifically dental health professional shortage areas. That, as Scott indicated on one of his earlier slides, Florida, over 5 million people live in dental health professional shortage areas. And just from a workforce perspective, to get that to the proper ratio, dentist population ratio, we need 1,200 new dentists in the state. And our argument is new dentists are not going to solve the problem because they are the most highly paid members of the dental team. And if we can find a way to deliver high quality, cost-effective care to these populations with a new member of the team called a dental therapist, that's what we ought to try to be doing. Next slide. Another indication of how difficult the problem is in Florida. I'm sorry I don't have updated data on this, but I can tell you, I've seen the data for 2019. It's just as bad. Florida ranks, this is the Medicaid utilization. What percentage of children who have a dental benefit in Medicaid in Florida received at least one dental service in the year? And the national average is not too good. It's only about 49%. But if you look at Florida, it's only 39%. And one may say, oh, that compared to the overall national average, that's not too bad. That's over 1.3 million children in our state did not get dental care in the prior year. Next slide. And so what is the consequence of that? When a poor person is in dental pain and they can't afford to go to a dental office, they know enough to go to the hospital emergency room because the hospital is required by law to see them. And here we do have updated data. This is for 2019. I hope these numbers shock you as much as they continue to shock me. 152,000 visits in just our state to hospital emergency rooms for a preventable dental problem, with the hospitals billing out close to $400 million. And Medicaid was the most frequent payer for that. In addition, 4,300 people, children and adults, had to be admitted to the hospital because the dental infection was life-threatening. It wasn't just a toothache, it was a life-threatening dental infection, and they needed IV antibiotics and pain medication. And so our total for our state is $630 million wasted on preventable dental conditions. Because the only thing that happens in the emergency room is a prescription for antibiotics and pain medication. And frequently that's opioids, and that leads to another whole set of problems. And they're told to go see a dentist tomorrow. Well, if they couldn't afford the dentist today, what makes you think they're going to be able to afford to see a dentist tomorrow? Next slide. what is the biggest impediment to people accessing oral health care? And Scott Darius mentioned this issue earlier, and it is absolutely true for dental care. It is costs. And the trend is actually more frightening than just the impact of cost on poor people. This is a study that I'm quoting here that shows that this decrease in the utilization of dental care over the last decade crosses all socioeconomic strata. It occurs in middle class and even upper middle income folks. And the main issue is cost. How can we reduce cost is going to be one of the questions. There's no doubt about it that oral health literacy is also important. People don't know the importance of good oral health. They don't know the relationship between oral health and systemic health. Next slide. So what can we do? What are some of the solutions? So clearly, the kinds of efforts that we're doing tonight of improving oral health literacy of the public and of policymakers. Something we call medical dental integration. And I'll just give you an example of that. I'm working on a project right now where I have dental hygienists in pediatricians' offices providing preventive dental services to those children. And that's just one example of medical dental integration. A popular program is loan forgiveness to get dentists to go work in dental health professional shortage areas. And I'm also going to say the State Dental Association is always asking for improved Medicaid reimbursement rates, but there's a big but there. The evidence, the literature shows that they really don't have a long-term effect on improving access and outcomes. And for those who want that reference, I'll be happy to provide it, but it's a study done by the Oral Health Workforce Center at the in New York State, in Albany. More safety net programs such as FQHCs that have sliding fee scales. But the problem for FQHCs is they can't afford to hire a lot of dentists. And so that's why we're looking at workforce and dental therapists who cost less to educate and less to employ, but can provide a lot of the basic services that patients need. I'm going to talk more about that now. Next slide, please. So what is a dental therapist? And this is a definition that those of us working on this, I will tell you, none of us really like the name dental therapist, but we're sort of historically stuck with it as the name of this provider. But an oral health professional who works on a team with dentists under the supervision of a licensed dentist. That's always important to emphasize. And they can provide evaluative care, preventive care, restorative care, and even minor surgical care with the training that they have and the competencies that they have. Next slide. So this is not a new profession. It's new in the United States, relatively speaking, but it's had 100 years of use in over 50 countries. It was introduced in Alaska about 15 years ago, in Minnesota about 10 or 12 years ago, and it is now legislatively passed, authorized in 13 states across this country. And I'm not going to do a deep dive on the safety and quality issues, but I can look you all in the eye and say 100% of the published literature supports the quality, safety, and cost effectiveness and improvements in patient oral health outcomes. And again, I'm happy to supply references for that to anyone who is interested. So the Commission on Dental Accreditation, which accredits all dental education programs in the United States, has now passed accreditation standards for dental therapy programs. And they can be educated in about 3 years. And in our state, we're really quite lucky that state colleges have such low tuition that our hope and our goal is that not only will this be a provider who can give good quality oral health care to all populations in the state, but in particular low income and minority populations, but this is the kind of profession that underrepresented minorities and people with lower socioeconomic backgrounds can actually afford to think about getting into. And only one organization opposes dental therapy. Only one in the United States, and that's the American Dental Association and its state components. Next slide. So what makes dental therapy work? Number one, they have a very limited scope of practice. So I, as a dentist, have several hundred procedures that I am licensed, educated, and able to do. Dental therapists have about 50 or 60 of what I'll call the basic procedures, basic fillings, preventive care, restorative care, and even the extractions of very mobile permanent teeth or primary teeth, baby teeth. Second thing that makes them cost effective is they're able to work under general supervision. At least that's the legislation we're trying to pass, which is modeled after the national legislation. That means they can be in the office when the dentist is not there. More importantly, they can go to a site like a school, set up their portable equipment, and provide restorative dental services in the school. This avoids mom or dad having to take time off from their hourly job to bring Johnny to the dentist. And they lower the cost of delivering care. They have lower salaries than dentists. They have much lower overhead costs. I mean, they still need a dental operatory and equipment, but they don't have any of the expensive materials or lab costs that a dentist would have for the majority of their patients. Next slide. So, what do you want? If you want more information, feel free to contact me. Look at our website, Floridians for Dental Access. Look at the website for the National Partnership for Dental Therapy, or the website for the National Coalition of Dentists for Health Equity. So what happened this year legislatively? We just got blocked again by the Dental Association. This is our fourth year of trying to get this legislation passed. We've grown our coalition. We're now at 63 member organizations across the state. And I will add bipartisan organizations. So we have very progressive groups and we have very conservative groups. The James Madison Institute and the Florida Policy Institute are two good examples. But we're coming back. We're not stopping. We are going to try again next year. And it's a longer story that I will not get into, but we're actually pretty optimistic about the following year of getting legislation passed. So that's where we are with dental therapy. And
Frank, I would add, if you don't mind, that
Sure.
dental therapy legislation has passed now in about a dozen states.
Yeah.
Legislation just recently passed in the state of Michigan, where I live. Legislation is pending in about a dozen more states.
Right.
And dental therapists, as we speak, are practicing in about 6 states, as I recall. So
That's exactly right.
this is gathering momentum. It is certainly a thread that is turning into a rope, and it has a lot of traction. And many states are looking at this issue of access to care and the oral health inequities that result out of access to care, and see dental therapy as part of the solution to resolving those issues.
Thanks, Caswell. You're absolutely right. So, Dennis, that's our presentation. You're muted, Dennis.
Thank you very much. I always keep it on mute. I don't want to make any noise that interrupts, and then I forget to turn it off when I speak. Before we open it up for questions, would you mind, I noticed that in the, I was going to ask you to go back, but Jocelyn's taken the slides down and we don't need to bring it back up. The slide that was comparing the states, I noticed that a couple that were doing really well way off to the right. One
Yeah.
was Connecticut, which, having lived there, I know why it was doing well. But I noticed Texas was way up there in terms of their, how are they, and I always see Texas as sort of similar to Florida. So how are they doing so well?
So Texas, a number of years ago, did a very significant expansion of Medicaid reimbursement for dentists. There was a lawsuit.
Ah,
We actually had a lawsuit in Florida. So the literature says that if you just have a modest increase in reimbursement, you're not going to get a big significant effect. If you have a very large increase, you're going to have a positive effect. Now, on the other hand, that brought about a number of problems, including lawsuits about then overtreatment of children and providing care that wasn't necessary. But yes, that's exactly why Texas got the improvement that it did.
well, that's pretty impressive. We need to be looking at that going forward.
It's not going to happen, Dennis. I mean, in our state, we're not going to be able to look forward to a significant increase in Medicaid reimbursement. It's simply not going to happen. You have to find other ways to be able to get care to kids, children, and adults. And there are two ways that I can see doing that. One is expanded function for dental hygienists, and we're working on that also. And then dental therapy.
Well, I didn't bring up the question just to sidetrack your,
Oh, no.
but it's just, I was just amazed that they were they're literally almost off the chart, and I wondered why. So,
Yeah.
So let's open it up to questions. Keziah, do we have any that have come through?
I haven't seen any questions.
All right, well, I have one, and that is if we could do something today that would help make a difference in terms of getting the dental therapy legislation passed in the next session, what could we be doing?
So my response is get the public angry about the $630 million wasted in hospital emergency rooms. And the second part is help Scott Darius and Florida Voices for Health amplify these stories. These, it's one of my colleagues said to me many years ago that data is good, Frank, but data without tears is not as good. And you need the stories. The policymakers and the public who can afford care need to hear the stories. I'm very familiar with some of the stories that Scott's team has collected, and they're compelling. They need more attention.
It's interesting you say that, because I was on a Zoom call today with some of the historic individuals who were involved in the civil rights movement. And one of them brought up the quote that said, the quickest way between you and change is a story. It's not it's not violence, it's not marching, it's a story. That's really the most important thing. So it's interesting you bring that up. And of course, Mr. Darius knows that, and is not only are they doing it, but they've named their organization that, so that's great. Anyone have any questions for our panel?
Well, if you don't mind, I would add to the comment that Frank made and urge you to think about this challenge in the full context of oral health and not just access to dental care. I think that the issues of oral health also have traction, and it's helpful for the public policymakers and advocates and activists to understand oral health in its broadest context, and not just and that goes beyond just simply provision of dental services.
All right, that makes a lot of sense. I know so little I can be worse than dangerous. So, but it makes sense to me.
Mhm.
Other questions, comments? All right, well, I want to thank the panel for this evening. This has been recorded, and we'll be sending out the link And we encourage you to spread the news on social media about this. This is a really important issue. Think of the children and the parents and the families who are suffering without access to healthcare generally, and more specifically, access to dental health, good dental health. And I want to thank everyone that's been with us tonight, in particular our panel, and the work they're doing and the dedication that they've shown and continue to show for this really vital, crucial work. We really want to thank you.
Dennis, if you don't mind, there is a question in the chat box that I'd like to respond to. If we have.
Yes.
So the question is from, are you proposing that non-dentists will perform dental services? And the answer is absolutely yes. And the reason why is the literature clearly shows that the safety and quality of the services they are educated to do and licensed to do in our state, if we pass this legislation, working under the supervision of the dentist, is equal to that of a dentist, unequivocally. There is no literature that questions that. There's a lot of opinion that questions that. There's a misrepresentation that questions that. But the literature is unequivocally clear. And yes, we are meeting resistance from the dentists.
Yeah, it was another question in the chat.
No, the dentist does not have to be present. They work under a collaborative management agreement where the dentist is providing what we call general supervision in our state, which means they are employed by and supervised by a dentist, but a dentist does not have to be there. That is one of the advantages of how they work, because they can go into the school system, they can go into a nursing home, as they're doing in Minnesota and in other states, and provide high quality care. If anyone else has other questions, please feel free to contact me, and I'll be happy to discuss with you.
And Mr. Darius had to jump off, and he indicated the same thing. You could reach him. It's in the chat there, his email address. Well, once again, thank you, everyone. Appreciate all of your input, and particularly our panel. And again, for their efforts to really try to make a difference in this very, very difficult situation we find ourselves in. Thank you.
Thanks for hosting this, Dennis. Thank you. Thanks, Caswell.
Thank you. Thanks, Frank. Bye-bye.